MSK lecture, just to kind of show you, just introduce you. This is not going to make you proficient. This is not testable. But I want to introduce you to some concepts that you may use in a deployed setting or even in your family medicine setting, and then transition quickly to the venous access. Those slides, I'm only going to cover like the first 15 or 20 of that lecture, just kind of showing you a couple different techniques for vascular access, and then the rest of the time is practicing, focusing on the 3 core exams that you're going to be potentially tested on. Monday is going to be a practice day, so if those of you, I'll let the class leader put out information regarding that. Monday is just lab, hands-on, and then throughout the week, if you need extra time, reps, or whatever, we're available, lunch, after lecture, or whatever you need, okay? Everybody good? All right, it's good stuff. So MSK. We've kind of talked about some indications for ultrasound in the MSK population, like patients with the MSK complaints. Is that a very common thing that we see in the military? Yeah, so this can get quite extensive. And there's very dynamic ultrasounds that are done by like radiology team. They can do very specific MSK ultrasounds, and they're becoming more prevalent where we're actually ordering less MRIs and they're doing more MSK ultrasounds because it's dynamic. You can put a patient through a range of motion. Physical therapists are using it all the time. What are some indications you think that you would need MSK bedside ultrasound or point of care ultrasound?
Joint injection.
I'm sorry?
Oh, I said joint injection.
Yeah, sure. If you're going to do an intra-articular injection, it's nice to know. Okay, what else?
Structures.
Okay, to assess like structures, is that what you said? Assist or, okay.
Police hair.
I'm sorry?
Police hair.
Yeah, absolutely. So all kinds of things. I'm going to go over some of them so you guys kind of know. So the probe that you're going to use, with the exception of the EFAST exam, is going to be linear. Linear probe is what we're going to use for just about everything else. This is our DVT ultrasound, our ocular ultrasound, and this is what you use for vascular access and for MSK because it's superficial, high resolution, not deep penetration. And oftentimes we'll actually have to use quite a bit of gel, especially on tiny joints like a finger joint. It was a few classes ago, one of the females in the class, they were playing volleyball or whatever, and hurt her finger, okay, or no, I think it was her wrist. And she had an x-ray at biopsy and it was red as normal, okay, and she kept saying, man, something's wrong with my wrist or whatever. And so finally we got to block 5, which is typically at the end of EMED, not in the middle. We're doing an ultrasound there, you can see it, a break, like real obvious, and I was like, man, it was missed on x-ray. So she ended up having to get in with a hand surgery, but it had been broken for like 6 weeks or so. So we use a lot for that. But anyway, we're going to use a big gel pillow, just like we do in the ocular exam. So for small parts like fingers, things like that, you can actually do a big pocket of gel because you don't want to push on the area of concern or the area that's hurting somebody. Also, you can use water baths. Have you guys ever seen or heard of that? You can get like a little tub of water. That's really good for like feet and hand ultrasounds, and you don't actually have to touch the probe onto the finger or the toe or whatever you're looking at. It's just you're contacting the surface of the water, just putting just the tip of the probe in the water, and it actually gives you enough medium to actually see the bones, so it's pretty cool. Or you can fill up little gloves with water to kind of just give you distance so that the ultrasound beam and sound waves can actually travel through something and bounce off the tissue that you're evaluating. And then lastly, a little shout out to Captain Williams and his FLART. Okay, I guess you could use FLART for this as well. All right. So just to orient you to the anatomy, it's really, if you know just basic anatomy, you'll be able to kind of tell ultrasound pictures. It just takes a little time and reps for it to make sense in our brain. But if you'll look at this picture, you can actually see the epidermis, dermis. You see the fascia, which is this hyperechoic line, subcutaneous fascia, and then underneath there, and then some muscle. And what does muscle typically look like? Like if we're eating a steak before it's cooked, it's striated, right? You can see all the stuff in it. That's what it looks like here as well. You can see some striations, especially in the long view. And then bone, which is hyperechoic, blocks the ultrasonic image and sound waves from that point forward. So this is a finger. You can see it's a little round bone. I'll keep showing you some examples. So skin exam. What are some indications for bedside ultrasound to evaluate skin? We talked about this a little bit when we talked about DVT. What are some other things we can do to assess? You got a red hot leg. What are some other things? Infection, right? So cobblestoning. So here we got this patient with a red hot swollen leg. here, and we don't know, is this a DVT, is this cellulitis? So a lot of times we'll do labs, we'll do a D-dimer, we'll do the ultrasound from the popliteal fossa all the way up to the inguinal area. But we can do a quick bedside ultrasound and put it right on this area of concern, distal, in the distal leg, and see if there's cobblestoning, and this is what cobblestoning looks like. All that subcutaneous fat actually has a little bit of fluid or inflammation around it. It looks like a cobblestone street. Pretty cool, right? I think it's pretty cool. And you can tell right away at bedside before you've ordered any labs, like, hey, this is infection. But you're still gonna have to play their silly game as of now. So cobblestoning, so that's the thing. Also, this is again cellulitis. We can actually see cellulitis on the ultrasound. What's another indication that we need to know is there's cellulitis versus what? Yeah, abscess. In case we have to IND something. Sometimes people let their big old abscess with a punctum just kind of fester and be there for days, weeks. I mean, for me, I probably wouldn't do that, but some people, you know, not so concerned. They'll let it fester, and by the time you go and put a scalpel in it, not much stuff comes out. It's just like this inflammatory tissue at that point. All that fluid is resolved. So it's nice to know in advance when you stick the ultrasound probe if it's cellulitis versus abscess. Here's another picture of cellulitis. Can you all appreciate all that cobblestoning? Yeah, it's pretty awesome. Just little tiny fluid around the fat cells. Pretty awesome. We're going to blow through this pretty quickly. This is abscess. So what do you see here? There's an actual fluid collection, right? And fluid is usually hypoechoic or anechoic. And so you can actually discern. Now, what typically when somebody has an abscess, there's some surrounding cellulitis. So we'll see some surrounding cobblestoning and then a discernible fluid collection. And now we know, hey, I have to IND this. All right. And I also personally always do Doppler on the area, color Doppler, and just to make sure there's no vascular structures. Because believe it or not, sometimes somebody has like a forearm abscess, for instance. They always say they have a spider bite, but nobody ever sees the spider. By the way, somebody put a fake spider on my keyboard, and I think it was Chris Rogerio. So I just want you to know, game on. Okay, I'm gonna get him back. But I walked in my office and jumped and screamed today. So he's a malo amigo. Anyway, so abscess formation, we definitely need to IND that, right? Because that abscess isn't going to go away unless we get the pus out. So we're going to do a bedside ultrasound for that, and then we can see some surrounding cellulitis, which would respond to antibiotics. Sometimes people will use it for procedures. Like in this particular case, they're actually doing a needle aspiration of the abscess. So you can actually watch yourself go in real time and remove that fluid. I typically don't do needle aspirations of abscesses because usually, especially if it's MRSA, it's just super thick, or if it's like an epidermal inclusion cyst or something like that, it's just gross and it's thick and it's not going to go into a needle. But you can do real-time aspiration, and what's great about the ultrasound, which you all know, is it will tell you the depth of everything. So if I'm looking at the bedside with a linear probe and I have little tick marks and it tells me I need to go, you know, the biggest fluid collection is about 1 centimeter deep, I know that I don't have to go that deep. And if I do it in real time, ultrasound guided, I'm less likely to hit any kind of surrounding structures, vascular nerve, otherwise, or have complications. Then I can also tell after I've IND'd something, did I get all of it out? Are all the loculations out? Okay, so they have less recurrence. So it's a really good thing for you to use. And trust me, downrange, there's lots of abscesses, okay? Bad hygiene, bunch of bad conditions. I mean, it happens. Foreign bodies. So we can see foreign bodies on X-rays, right? What kind of foreign bodies can we not see on X-rays? What'd you say? Yeah, we can see glass. It should be radio opaque. But wood, organic materials, you're absolutely correct. We cannot see anything organic. So if they have a giant thorn or a splinter or a piece of wood, we usually can't see it. Or a tree branch, we probably wouldn't be able to see it because it's wood. But we can on ultrasound. Of course, we can see metal. Everybody can see this giant metal needle. Everybody agree? Or shard, whatever that is. Okay, that's a piece of steel. This is a needle. I guess somebody injected themselves and let the needle in, and I don't know how it got absorbed through their venous system. And then glass. Glass does show up. Not that long ago in Uvalde, there was this country bumpkin that I saw. He was like 78, hadn't seen a doctor in like 20 years, and somehow he fell through his glass door. I don't know if he was drinking or if he just tripped or whatever. He fell through his glass door, and he cut himself. He had this big, huge avulsion right around his, just proximal to the elbow. Anyway, so he just decided to do the, a little compression, wrapped it all up, and business as usual, right? He's got a business to run. So few weeks later, he starts getting infection. It's red hot, swollen, leaking pus. So he finally comes in the ER, and he's like, "Look, I don't have insurance. Just give me some antibiotics." And I'm like, "Well, let me just stick an ultrasound probe on there." And this is what it looked like. It was like a huge piece of glass in there, and I measured it. It was like 3 by 4 centimeters. And I was like, "You still have glass in there. It's no wonder I had somebody. You probably had to have surgery because it was so deep and close to the joint that, you know." And he wouldn't allow us to do any other imaging. So I said, "Listen, I'll try one time." Because going after foreign bodies is kind of bad medicine. If you ever don't do it, okay? So he's like, "I can see it, you know, don't do it." I watched surgeons in an OR dig for a bullet in a buttock wound, the Afghani special, where they would go in and they would get in the back of the vehicle and they would accidentally shoot each other in the butt, their own people. And so they'd have like an impaled bullet in their buttock, and so they'd come in and I'd watch these surgeons, they'd look at it, ultrasound, CT, everything that we had, and they would go for hours trying to find that thing. So foreign bodies are bad to go after unless you absolutely have to, like a kid that sticks something in their nose or ear. Maybe you might want to try once before you get into EMT, but in general, we don't go after them. So anyway, I went against my own ethics and was like, okay, I'm going to go ahead and give this guy, because he put me in this position. He doesn't want to be seen, he's going to refuse surgery, he says he doesn't have insurance. So I stuck my hemostats. I kind of had to open him up a little bit because it started to close. I stuck my hemostats down there, and I kind of felt it scrape against the little curved hemostats. I could feel it. And I'm like, okay, if I get a good grip on this, I might be able to pull it out. And I made sure I ultrasounded all around it, and made sure I wasn't hitting any kind of vascular or nerve structures. So I was able to get a hold of it, and I pulled it straight out. And it was a huge piece of glass. I mean, I was surprised. It was like 3 by 4 centimeters. So anyway, it will be helpful in the most unusual circumstances that we're sometimes placed in. Again, glass, radio opaque or hyperechoic on ultrasound. And then gravel, even gravel, that matters, right? Everybody's like riding their bike or motorcycle, you get a gravel injury. You can actually see gravel here with cobblestoning around it, so it's been festering for a few days. So foreign bodies, all right, and that goes for the eye as well. And unlike X-ray, we can see organic matter like thorns, wood, things like that. There's a piece of wood, and you can actually measure the depth. So if you wanted to go in after that, by all means, go for it. I probably wouldn't. All right, tendon injury. This is important, right? Give me an example of somebody who would tear their Achilles. What's the typical patient presentation? Yeah, this older guy usually. It can happen to women, but usually it's like, I'm going to school him on the basketball court, and I'm going to show him how my skills, and play with these 20-year-olds, right? And I'm going to school them, and they go to take off, and they feel like somebody hits them in the back of their leg. And they look, nobody's there that hit them, but they swear somebody hit them. Is that how you guys were taught? That is how they really say it. They said, somebody hit me. Like, I couldn't find him, but I know somebody hit me. Because it's just such a violent thing that happens. So this is a really good indication, and it's real easy. We usually look at tendons in the long and short axis. Unlike, this is where some of the rules of ultrasound kind of don't apply. We don't necessarily need the probe marker to be right or up when we're doing specific tendons. We want it to be perpendicular to the tendon to look at it in the long and short axis. So whichever direction that particular tendon is going is how you're going to orient your probe. Anyway, it's pretty awesome. So usually we'll look at the Achilles tendon, we'll look at its insertion right at the calcaneus, and we'll kind of follow it up, and we'll follow all the way up till it kind of disappears in like the soleus muscles and things. It's really awesome, and I'll show you how easy it is once you get oriented. So remember, we can see the superficial structure. You've got epidermis and dermis. The tendon, actually, you can see this fascia here and here, and you can see these long linear lines that are consistent with tendon. Will you all agree that's what a tendon looks like? It may take a little while for you to get used to it, but you can actually just follow this along and see if it's intact or if there's a partial tear, full tear, and I'm going to show you some examples. So this is a real life video, and when we're going through, and right here it looks like there's a little disruption, and that's actually an artifact called anisotropy. So sometimes because the tissue is striated and it's so superficial, the ultrasound interprets when there's not a beam coming back to the probe, it interprets that as dark space, and so sometimes it'll look like a tear when it isn't. So in the right context, that's why we do two views. You want to look at the short axis as well to make sure that you don't see that artifact and overcall something. But is it better to overcall or undercall something? Overcall all day, right? Nobody gets hurt except for your little ego, right? So what do y'all think about these two? This is a long axis, so they're just traveling from the insertion of the calcaneus proximally And then you see like some empty space here and fluid. You agree? That's an obvious disruption. And when you look at it in the short axis, you can actually see there's a piece of it missing. So we're going along the tendon, then we kind of flip our probe to kind of cut the tendon in half. There's actually a deficit, which is what we're supposed to be able to palpate, right? We do our bedside maneuvers. What's that test called? When we do the calf squeeze, what's that called? What's it called for a tendon? Yeah, okay. I think it is the Thompson's test. It is Thompson, but somebody said Thomas, and I was like, maybe, no, it's definitely Thompson. Okay, Thompson, yeah, it's the same thing where they can, like you sit on a gurney or bed or whatever, you squeeze their calf muscles, they should plantar flex, all right? If they can't do that, the Achilles usually is not intact. If they can, usually it's at least partially intact. But anyway, there's a deficit here. I'll keep going. Again, also you can measure, and sometimes you'll just see like inflammation or fluid around it, like right here, there's fluid, and you can measure your depth. So what do y'all think about this one? I know it's hard. So this is tendon here, these are the striations. What do you see? I'm gonna play it again because it was a quick video. Yeah, it looks like there's stuff in there, right? So this is a chronic tendinitis in which there's actually fluid collection, and this is an older person to the point where there's actually calcifications which appeared like gravel, so whoever said that was awesome, but they're calcifications from chronic swelling and just inflammatory changes which happens. So when we are trying to detect or diagnose partial tendon ruptures, we're looking for a change in width, maybe a focal hemorrhage or fluid collection, or the lack of retraction with movement. So just like we do the eye static and dynamic exams, you're going to do the same thing when you're evaluating someone's tendon. You're going to look at it just in real time, not having the patient move, and then you're going to have them plantar flex, dorsiflex, plantar flex, dorsiflex, short and long axis. You're going to see a dynamic exam. And so when you put them through a range of motion, you can actually see pathology a lot more easier than not. And so that's the focal deficit there. Effusions. When might this be helpful? Do we care about just swelling of a joint? Yeah, we do care. It could be like a septic joint. There's all kinds of things, or sometimes we have to actually drain these things. I try not to stick a needle in joints if I don't have to, because we don't want to introduce infection, but sometimes we do, and again, you want to get it in 2 views, and I'll show you. So we can do, a lot of times if they have any kind of knee pathology, they'll get swelling in the suprapatellar pouch, but you can actually do the lateral, medial, and even distal areas when we're looking at the effusion. So you just go to whichever compartment is most tender or looks obviously inflamed or edematous to you, and you can look. And so here on the left, you'll see this is a person that has a large fluid collection. This is the suprapatellar pouch, and it's just fluid. Okay, this is from a tendon injury. They actually tore their ACL, and they actually had a huge suprapatellar effusion. And so this other side, this is an actual real-time video of somebody sticking a needle in the suprapatellar pouch above the knee, and actually they're taking out the hemarthrosis to reduce pain in a patient. I personally try not to do that. I try to talk them out of doing it unless it's just really huge, like really, really huge. Otherwise, the risk of infection is really high, especially if it's a hematoma. That's like food for bacteria, so I try not to do that. But if you're working as an ortho PA, you might do a lot of these. It might be a lot more indicated than just the emergency department. What do y'all think here? Kind of hard to see, right? So what they're looking at, and they're looking at an effusion, but they actually see that this white bone is disrupted. You got white bone, nothing, then white bone, so there's actually a patellar fracture. They can do elbow, you can do any joint. I'm gonna go through these really quickly because again, this isn't the focus, but you can imagine like a pediatric patient, all those little fusure injuries and supracondylar fractures. If they have enough to produce edema, you can actually put the probe posterior and anterior, and you can actually see the effusion. And this is what it looks like. This is the capitulum, and you can actually see an effusion there, just above the radial head. Okay, fractures I think are going to be more easier for us. I do this a lot for like rib fractures because chest x-rays are really hard to discern. Even if you do a chest x-ray with rib series, most of the time we only care if the underlying lung is intact or not. So traditionally when somebody thought that they had rib fractures, we do a chest x-ray, but we really don't care that much about the rib fractures unless they have like a flail chest. It's just painful, especially in elderly. But we can easily do a bedside ultrasound and just follow the bone line, and any disruption, like this is a rib right here, you can see bone, which is hyperechoic white, and then it just a clear disruption, right? It's so simple to do, and they're so superficial that you can nail this diagnosis all the time. Same here, this is a fifth toe, so we got a fracture here right before the fifth MTP. So here's the joint, and then we have like a disruption of bone here. And then here's a sternal fracture of a patient that hit the steering wheel during an MVC, and you can see a disruption. They came in with sternal and chest pain. You can actually see the disruption with a little bit of displacement. So pretty good stuff, right? Seems pretty easy? Okay, I think so too. What do y'all think about this video? You think nothing of this video? It's not. What do you think about this? It says fracture, so it's probably fractured. But, yeah, we got white bone here, and then again, this is another digit, and you got disruption here. This is exactly how the wrist of that one of our students looked a few semesters ago. And then this is obvious. This is a wrist, and there's some displacement there. Would you all agree? So you can actually tell if it's angulated, comminuted, displaced, not displaced, just by the ultrasound. What do you think about this one? It still says fracture, so it's probably fractured, right? Yeah, so that's the right wrist. I know it's hard to tell, but any break in that contiguous white bone, the cortex, you'll be able to see it. Even green stick fractures, sometimes you'll actually see like a little subcortical hematoma, which will kind of cue you in that there's a fracture. So pretty straightforward, right? And you can do foreign bodies in the eye as well. I didn't cover that during the eye lecture, but you can use it for all these things. Any questions about what we just covered? Was that too fast? Too slow? Okay, all right. Is anybody interested in learning how to do peripheral ID or vascular access with the ultrasound? All right, I'm just gonna cover like the first 15 or 20 slides because the rest of it gets into the science and angles and math of it. So I'm just gonna